is Carolyn Kiefer. She's an RN and an infection preventionist here with an infection control, and she's going to talk to us about building an ambulatory infection prevention program in the world outside the hospital. Does that really exist outside the hospital?
There is, and it's a great big world. I'm excited to share with you what Joe and I, my colleague, she's back there in the corner. Hi, Joe. Did to move infection prevention to our ambulatory facilities within Carolyn. So some background, in 2012, during a Joint Commission survey, they identified that we had patient safety issues in our practices and infection prevention oversight, it was needed. So why this is significant, well, this is probably from some of my most favorite images when it comes to ambulatory is that ambulatory facilities greatly outweigh inpatient facilities in the United States, more than 580,000 compared to around 5,600 for hospitals. But wait, there's more. Ambulatory healthcare is anticipated to expand to more than 18% by 2024, while inpatient healthcare will decrease to -3%. Well, knowing all that, those big numbers and those graphs, that there's just a really cause for concern because ambulatory infection prevention is either deficient, non-existent, and outbreaks and exposures occur, but they go unnoticed or unidentified. Patients may not have symptoms of infections such as with hepatitis, or if they do develop symptoms, it may be months and months later and not know where they picked it up at. Or also, health departments aren't required to share any of the investigations that they do, so that cannot be in the public knowledge. But the exposures that were identified from 2007 to 2014 and reported to Centers for Disease Control, there are 34, affecting more than 94,000 patients. This is a surprising fact to me. I wouldn't think about this, but more than 80% of our injection practice outbreaks, they occur in ambulatory facilities, not in a hospital where you think of more injections might be given. There were 35 events across 17 states from 2001 to 2011 and affected more than 130,000 patients. So Joe and I had a big aim and an even bigger target. Both of us were designated to our clinics in 2013, and we were tasked with developing an approach for ambulatory infection prevention, tailoring it to our outpatient environments. For Carolyn, we have more than 180 outpatient sites that span 214 miles, ranging from Dayton, Virginia to Tazewell, Virginia. There's more than 1 million visits that were made to our sites in 2014. So it's pretty vast. That's the world outside our hospital right there. The setup of our program, the basis is a scored risk assessment survey tool that was based on Centers for Disease Control, OSHA, Joint Commission, other relevant guidelines and standards. It helped us evaluate site infection risks and identify areas for improvement, whether they existed in the environment, with processes, or staff knowledge. The categories that we looked at were surrounding hand hygiene, disinfection, sterilization, and cleaning, use of personal protective equipment or the availability of it, medication, and supply management are a few of them. So those are categories that we evaluated, and they were tabulated as a percentage for the category risk or as an overall site risk of all the combined categories. So we traveled more than 8,000 miles. I know my car is feeling it, and I know Joe's is too. Made more than 206 visits, and the scores were compiled for sites that had multiple revisits, as you can see the graphs here. The most striking graphs are those related to instrument reprocessing. We found some issues along the lines, but it helped us identify how we needed to support the practices, what we need to do for them, the help that we need. Thank you, Gloria, who's back in the room, from helped us with our processes. We couldn't have done it without her. You can see the ends vary because not all the sites did the same processes, or they might have switched from sterilizing on-site to off-site based off of our guidance. And here are the overall site compliance risks for all of our clinics combined, and you can see the increase from 83% in 2013 to 91% in 2015, and only continuing to improve. But there had to be follow-through to see those scores improve and the risks decreased. We researched information regarding manufacturer's instructions. If it touched our patient, we told them it either had to be a disposable item or we need to clean, disinfect, or sterilize it appropriately. We need to locate literature to support our findings, because how can we change practices that have been in place for years without telling them the rationale behind it? We standardized where we could, related to equipment, processes, or supplies. We also developed ambulatory specific policies, training, and competencies. The majority was that related to disinfection and sterilization, and Gloria helped us with that greatly. And we couldn't have done it without the support with our multidisciplinary team and how being able to work collaboratively, and that involved, as I mentioned, Gloria, with our central sterile experts, leadership, materials management, pharmacy. I mean, there was just a lot of people that have really supported us. Facilities management. I'm sure I forgot some, and I apologize. We emphasize the importance of standard precautions. That's our hand hygiene, cleaning, disinfection, sterilization, use of personal protective equipment, to name a few. And during the whole time, we continuously and tirelessly supported and educated anybody who would listen. And our ultimate indicator of what we did and the effectiveness of it was during our Joint Commission survey this in 2015. There were not any infection control citations. And Joe and I know we did a lot, but we would attribute that to our staff and all the work that they put forth. That was their opportunity to shine. We have a standard tool for measuring infection control compliance, and we've been using it for about 3 years and continue to use it and modify it based on our clinic's needs. It's accepted by our staff and the leadership. We see the results as opportunities for improvement, and they're acted upon, again, as a multidisciplinary effort. And focus has increased for infection prevention, as well as practices have improved in our facilities. And we're very excited to be a part of this and seeing how things will only continue to improve, and the excitement of our staff and that their openness to be able to change practices and learn more. That's it. Thank you. Does anyone have any questions?
You should have brought your pictures.
My pictures. I didn't have enough slides for those. Yes.
Some of the things that you found were just amazing.
And it's a different world out there, and I said it's a huge world, but half of our sites are Joint Commission surveyable, the other half are not. And so our practices that may be in our outlying areas don't receive the same information and support as our practices around this area may take for granted. So there have been a lot of things that we've addressed that you would be surprised that occurred in practices, but things have really improved, and we're very proud of the progress. Does anyone else have questions? No. Thank you.